Good morning, everybody. I think I'll get us started and encourage you as we start, for those of you who are in the room, to go back and help yourselves to the coffee, what look like really great muffins. And with apologies to those of you who are on the webcast that we don't yet have the technology to deliver those online, but hopefully you're sitting with your own coffee and enjoying yourself. So this is a great privilege to be able to talk on this topic, and I really want to thank Marilee Hughes for helping to organize it, Suzanne, Dr. Suzanne Campbell, and the rest of the school for creating a space for this kind of discussion. And it's been something that I've really appreciated having the opportunity to do, and want to start by acknowledging a couple of colleagues who've helped me with some of the workup of this, and we're planning on working on a paper. So I'll be taking notes on any of your questions or comments. The two colleagues who I want to acknowledge, one is Dr. Rosalie Starzomski from the University of Victoria School of Nursing. She's a professor there, and she and I and Dr. Jan Storch from the University of Victoria have shared an interest in end of life for a long time, and this has given us a chance to talk more recently about it. And I also want to acknowledge a doctoral student that I have the pleasure of supervising, Lynn Musto, who has a focus on mental health, but has some very particular insights about the implications of this in terms of mental health. So this is a conversation that we really need to be having right across the country. It is ramping up, and I think that at the School of Nursing we have a great deal that we can contribute. So we are a webcast, so what I'm going to do is proceed initially in a somewhat didactic manner. That is, go through the slides, give the conversation, and then have a question chunk at the end. Normally I like to do a bit of back and forth, but it's hard for the web folk because they won't hear you and so forth. So I'll be repeating your questions when we ask questions at the end. Everybody got that? So I also wanted to mention that the webcast is, of course, archived and is available. And I've also given permission for the PowerPoint to be posted on, now remind me where that was, sorry. On the website on the events listing. And one of the reasons for that is the slides have some points on them, but more importantly, I tried to pull together a fairly good reference list for those of you who are doing work in the area. So it's representative of the kind of wisdom in the field. So the first thing that I want to say is that the Proceed with Care heading on this is chosen for a reason, and it really reflects a great deal of what I'm going to say this morning. At the end of this PowerPoint, I did note that I'd scooped that term from, now I'm going to be dating myself, but from 1993, the Royal Commission on New Reproductive Technologies came out with a 2-volume report that had the heading Proceed with Care. And for me, it very much fit what we ought to be doing at this stage. So what I'm going to do is start by just giving a brief synopsis of what's happening in terms of physician-assisted death, because of course it's been changing quickly. There's been a great deal happen within this last year. I'm going to follow my title and start going through some empirical reflections, ethical reflections, and policy reflections. And as anybody who's been in my classes know, when I get excited, I talk fast. So if my speed of speech, which might have happened on the radio, I'll go home and listen to that later, but if my speed of speech exceeds comprehension, just put your hand up and I'll slow down. But it is wonderful to have a chance to be here. And by speaking about the radio, there was a brief clip on the morning edition with Rick Clough on this topic that I had a chance to participate in, and you're way less scary than being on the phone on a radio, so thank you. I'm quite relaxed. So as you know, and this, by the way, it took me a little while to track down the context fully because things have been changing so quickly. On February 6th, in 2015, the Supreme Court of Canada declared in the Carter versus Canada federal court decision that the absolute criminal prohibition of physician-assisted death, it's abbreviated PAD, was unconstitutional. I do want to, by the way, say that like any new emerging trend, there's a few different terms for this. One that seems to be most consistently used is physician-assisted death. So that you'll see that most commonly, but don't be surprised if the terminology shifts some more. So that happened on February 6th in 2015. At that time, the court specified certain circumstances in which it must be lawful for a person to choose physician-assisted death and gave the federal government 1 year to enact a legislative response within its jurisdiction, failing which the provision of PAD meeting the Supreme Court's criteria for eligibility would be ungoverned by criminal law. That's a long-winded way of saying get your act together and get some policies in place because it is happening. And in my view, a year, especially as I get older, that's like light speed, incredibly fast, very dramatic requirements for all the professions to respond. And I do have some resources in terms of Canadian Nursing Association responses and others, but that is not a lot of time to come out of the gate to sort this out. And I'll say more about what our palliative care colleagues have been contributing to this discussion because it is enormously important. So before I do that, I'm then going to just say a little bit more about the context. And the circumstances then are that the individual who makes a request for physician-assisted death needs to be a capable adult. That means having competence. The consent is clear and voluntary. All of us know that's really easy to put as words up here, not so easy to assure in terms of clinical context when people are feeling vulnerable, in pain, and so forth. But certainly the clarity, the normal rules of consent apply. And the illness, disease, or disability is grievous and irremediable. And that, of course, is itself a point of some discussion, but that's part of the definition from the court. The suffering is enduring and intolerable to the individual. So we won't get into a whole lot about what's loaded in there. There's lots of good material on the web to look up, but a couple of points I do want to make, as you know, is that and initially, it was a fairly wide scope on the table, including challenges with mental health problems, potentially for mature minors and so forth. And right now, we're with a fairly narrower scope of who would be eligible to apply for physician-assisted death, which is, going back to the proceed with care, which is likely a significant a good starting point, better than it would be if the doors had been thrown wide open. And I do want to add that we have a great deal of work to do to understand how mental health and mental illness fits in here. When we think of suicide, for example, as one of the symptoms of mental health challenges that we want to treat, not enable, and also given what we know about serious problems with mental health care access. So that in particular is an area that we in our profession are going to need to watch carefully. So all of this, the year was given, the date was extended, so the go live date, as it were, is June 6th, 2016, which feels like tomorrow right now, so not a great deal of lead time. So let me start then with the empirical reflections. And I do, as I said, I tried to pull together a good reference list. So I didn't reference everything I said, but it's in the references. So I'm not making up the empirical stuff. You'll be able to find it in the materials. And so the summary points I want to make are that there's long-standing and serious inequities to access for resources for appropriate health and health care, and I'm distinguishing those, by the way. You know that the resources for health are not necessarily the same as resources for health care. For example, resources for health are closely tied to the social determinants of health. For health care, of course, are more governed by delivery from the provinces linked to the federal government. Certainly, we have serious inequities in access. And those inequities in terms of health care run right through acute care, home care, long-term care, and palliative care. So all of those fields have challenges with access. So an individual living with a life-limiting illness is not going to have an easy time in any one of those domains. I'm not claiming it's all catastrophic. Although I sometimes feel like Chicken Little saying the sky is falling, the sky is falling. But we've got serious challenges. The data is pretty increasingly clear on this. For example, including in particular, the second bullet point, the inequities we know in our School of Nursing, our Cry-High unit here has done some great research on this. Inequities are especially pronounced for Aboriginal peoples, those with mental health challenges, those who are impoverished, those who don't speak English or French as a first language, depending on their province, people living in rural and remote communities, and older adults. And I have to say, as somebody who's taught a fair bit in the undergrad program, when I ask for stories of ethical challenges and see the reports come back of the really abysmal care of older adults, you know, being wheeled down a hall without a sheet thrown over them as they're naked going into the shower because it's quicker to be able to do that and so forth, that there's a lot of serious issues with older adults as well, right across the spectrum. I'm not saying all healthcare is catastrophic, but in order to proceed with care, we really need to have a sense of how these factors are going to influence people's ability to choose. So despite significant work then to support better end-of-life decision-making apart from physician-assisted death, for example, we've had some good work going and still going on advanced directives. We've known about this and been trying to implement it for about 20 years, and I think that there has been good progress made. But what we're finding is still, and the research continues to show this, that many patients still experience what they would consider to be overtreatment at the end of life. There's some populations where this is particularly difficult. If you have a cancer diagnosis, for example, I won't say it's easier, I don't want to trivialize that, but the end-of-life discussions may be more straightforward depending on what's known about the disease. But one of our doctoral students, Jennifer Gibson, is doing her dissertation work on patients with congestive heart failure, where heart is seen as treat and cure almost automatically as a cultural phenomena, and yet many people with serious congestive heart failure have just as high a mortality as metastatic CA, but they don't get the end-of-life options. So there's some craziness in the way that we look at how people are on that end-of-life trajectory and offer them what they deserve. So certainly this means that the impacts on patients in terms of, for example, suffering, families, for example, in terms of their grief, and healthcare providers in terms of moral distress is significant. Again, well chronicled in the research literature. So having sort of sketched where we have significant challenges, it's important to say now what are we going to do with this? And it would be really nice to have the coffee and the muffins and walk away saying we better do something, but it'd be better if we had the coffee muffins and started to say, what might we do? How can we move forward? What is happening, and how can we as a profession contribute to this? And how can our scholarship contribute to this? So something that informs the work of places like the CRI-High unit, certainly our undergraduate program, and the School of Nursing overall, is that we're well known for our critical theorizing. And what that means is that we are part of an increasing cadre of scholars in nursing and other fields who are interested in the power dynamics that affect individuals. And that means that in proceeding with care for individuals and groups, we really need to understand, looking at that diagram, how the individual is nested within a relational context that includes their family, their community, the organization or organizations that they find themselves in, and the larger healthcare system. That it means that looking at this just as a matter of individual choice trivializes all the other layers that influence their ability to choose. Are you with me on that? So really key point that has not been, I believe, and I don't claim to be an expert in the physician-assisted death literature, but certainly is not discussed enough, that the inability for somebody living in a rural community to access palliative care without having to drive 2 or 3 hours and so forth is a serious structural challenge to the ability to choose. So that means that as we look at moving forward, we ought to think of praxis, meaning practice that is informed by attention to power dynamics at all levels. And certainly within nursing and our colleagues in other fields, I think we increasingly have the skill and the ability to navigate across these layers. So the proceed with care then is to navigate across those layers. So, and that will definitely inform what I say about ethical reflections. So what I might just do before I go to the ethical reflections, I was saying I'd stop for questions later, but maybe I'll do a midpoint check-in and see if anybody has any questions about what I've said thus far. I'm going to go to some ethical points and then on to policy points about how we can move forward to make this better. But in sketching out the context, maybe I'll just see if there's any questions or comments, and also in a good ethics discussion, you have to feel free to be disagreed with. So you can also challenge anything that I've said. That's healthy as well. So any comments or questions? I'll go to the room, and those of you online, if you, and the way they do this is they send a note to Marilee via the chat box. There's a chat box. So Marilee is keeping an eye on the chat box. Go for it. Thanks. And I'll repeat the question up here so it's heard. Go ahead.
When you're looking at guidelines put forward by the Supreme Court, so just to clarify from my own understanding, the decision as to whether or not an illness is grievous, that's being made by a healthcare professional, but the decision of whether or not the suffering caused by that is ultimately by the individual.
Yeah, well, that's a really good question. So let me repeat it and correct me if I paraphrase you incorrectly. A really important question. The decision about is the disease irremediable, I can't even say that word, it's a bit of a tongue twister, is made presumably by the healthcare team, but the suffering being intolerable is the individual perspective of the patient. That is my understanding of it, but I don't claim to be a legal expert in the interpretation, and one of the most important sources I'm going to point everybody to is the Joint Centre for Bioethics at the University of Toronto has a huge mandate to pursue this and is publishing papers and papers on just these kinds of questions. So some of what I'm presenting today I've drawn from there, but that's an excellent question. And I do know that some of the debate is turned on the notion of what does intolerable suffering mean? And that's a particular issue, for example, for mental health patients, in addition to others. So I think that you pointed to some of the areas of question. There's a question online, and I'll repeat it merrily after you.
There's actually two questions. One from Joanna. Are you concerned that nurses are not specifically named in the Bill C-15 that was tabled last week? And then the second question.
Okay, well, I'll do the first one first. So Joanna sent in a question, thank you, saying, am I concerned that nurses are not specifically named in the Bill C-50, it was 51 as I recall, that was tabled last week. And I think that the absence of nursing in this discourse is really important, that the focus has been on physician, and we ought to be named more explicitly in terms of both the people who provide the context for care and support. There has been some of what I was reading, the P instead of PAD, physician-assisted death, some people were writing about it as provider-assisted death, and that could potentially include NPs and so forth. But I think the support for assisted death is more than just the giving the injection, and ought to very definitely be how does the healthcare team, which includes nurses, social workers, and others, support patients and families through this trajectory. And I think that the focus has been too much on the individual context of an individual decision in that moment, giving an injection, which is important, but the rest of the story matters, and I think that the legislation hasn't necessarily pointed us to that. So that was a long-winded answer to the question. That was a very good one. And I do want to say that the Canadian Nursing Association, I've got a web link on the references, has been speaking up about supporting and being available to participate in this discussion. Second question. Thank you.
The second question is a terminology question from Lillian about whether there's any implications of using the term PAD versus PAS as a physician-assisted suicide.
Yes, so the question is there terminology implications of using PAD, physician-assisted death, versus PAS, physician-assisted suicide? And again, I point people to the Joint Centre resources. So I'm letting you know what I know about this without claiming to be a full expert on it. My understanding is the concern about the use of the term suicide is that it has a connotation, a subjective connotation that many people would find troubling, because many people feel that this is a death that would occur at the end of this trajectory of illness regardless, and hence the word death or dying is preferred. The other point that's important is that it's being distinguished from euthanasia in the sense that it is the person themselves who is asking for this initiative. And there are a lot of terminology debates in this, so it's a really good point. But what seems to be being landed on right now is physician-assisted death, and I would encourage you to read critically in the literature to keep watching what happens with that terminology. Even in I first got really involved in a discussion in this about a year ago, and even then the terminology was different. It seems to be shifting quickly, which is reflecting some conceptual shifts, I think, as well. So excellent questions. Anyway, we can take one more from the room, and then I'll keep going. Anything else? We're good? Everybody with me so far? So what are we going to do about this? The ethical reflections then, the first set, I've got two sets of ideas from ethics that I think can inform this. The first are from the Joint Centre for Bioethics at the University of Toronto, and By the way, I do want to say that people who do ethics work at the Joint Centre and across Canada are fairly well connected through the Canadian Bioethics Society that myself, Rosalie, and others, and Dr. Jan Storch have been very involved in for a number of years. And the Joint Centre is a good microcosm of that they have very good interdisciplinary mix. They have good philosophers, social scientists. Dr. Elizabeth Peter is a nurse who has a great deal of leadership in the field as well. And they have been doing some very serious work in this. And in terms of the list of ethical principles that they've flagged as key, and remember this work is ongoing, so this isn't going to be the final answer, but in their current document, they certainly are looking at this being a reflection of patient autonomy and self-determination. And that's absolutely the case. That is what is driving these individual requests for physician-assisted death, for people to decide themselves whether this stage of the illness is irrevocable or the suffering is intolerable. Beneficence and non-maleficence, meaning that we ought to be guided by doing good and avoiding harm. And of course, that's a difficult determination when somebody is suffering extensively and when we're not exactly sure how an illness may progress or whether, in fact, better access to palliative support could mean that we could do more good rather than having to go quickly to a hastened death. So lots of questions about beneficence and non-maleficence. The Joint Centre also points out that fairness in terms of access to all resources is important, and that's when the word fairness is used, it's often used in a distributive sense, so that there ought to be more distribution, for example, of palliative care beds, home care palliative care support, and so forth. They also talk about equity, and you know, I think probably everybody in the room and on the online knows, because we flog it here at the School of Nursing quite rightly, equity means not treating everybody the same, but it's paying attention to the situations people come from and treating like situations alike. So a really bad way to approach fairness is to say, well, everybody gets the same option for palliative care regardless. But if we ignore that somebody doesn't have the money to be able to get on a bus to come to the clinic, or somebody has absolutely nobody living at home with them and so forth, then we've truly violated notions of equity, that we ought to look at the situations of people's lives and treat like situations alike. The other emphasis that the Joint Centre gives in their paper on this in terms of our ethical reflections are that the moral character, if you will, of the healthcare provider really matters. And that means that we ought to be looking at professional virtues such as compassion. And the example I gave of some of the warehousing of the elderly shows that we do have areas where we have work to do. And certainly then that needs to be an emphasis. And as we know, and I'll say more about as we a little bit further, is that healthcare providers need support to be able to enact those virtues as well, that we are often in understaffed and really busy environments. That can be a serious challenge. The other reflections that I wanted to add, so if I was editing the Joint Centre list, I'd widen these reflections a little bit to some other ethical constructs. Some of the most interesting writing about autonomy has been about a relational approach to autonomy. It goes back to that diagram that I shared with you, that as we think about an individual choosing, we ought to never think of them in isolation. And unfortunately, our Western approach to autonomy tends to do this, and legal approaches to autonomy tends to look at the individual kind of as in the absence of their context. Relational autonomy reminds us that the individual is always nested in those relationships and in that community and organizational context, and it asks us to consider that. So it's not arguing that the family gets to override what the patient says, but rather a good analysis of where somebody is at with this dying trajectory and their suffering should be what kind of support is the family able to give, what else is a good family assessment, what else is happening, what resources truly are in that community, and how can we move forward. So a relational approach to autonomy gets us out of that kind of rigid box of yes, no, competent, yes, no, irremediable, yes, no. It's an oversimplification, and a relational approach to autonomy widens that. And that I'm drawing on work by Dr. Susan Sherwin, an ethicist from Dalhousie. Another principle that I think really ought to help us move forward is the notion of fidelity. And Fidelity is really a focus on trust that comes out of Catholic theology in particular. Healthcare ethics has got a rich heritage, that some of which is religious, some of it's secular. It's some of the best stuff now is also social science informed, but we've got a composite approach to theory that gives us a pretty rich package to work with. And Fidelity, I believe, is one of the most important constructs, because what we ought to be able to say, and here I'm quoting an ethicist from Fraser Health, Dr. Bashir Jawani, in a teaching tape we did a few years ago. He expressed this beautifully. We may not be able to say to the person, look, we can take away all the angst that you're going through. We may not be able to say we can take away the disease, but what we can say, and too often don't, is we will stay with you. In other words, whatever happens as this journey unfolds, we as individuals or within our professions will stay with you. And that's that notion of trust and fidelity and relationship. And so for those of you who are in our undergrad program, this is certainly going to sound like what Dr. Colleen Varco and Dr. Gwyneth Hartrick-Doan have written about in terms of relational practice. That regardless of where somebody is at their choice journey or their palliative journey, or if they're on the threshold of physician-assisted death, that sense of we as professionals will be with you is absolutely crucial to deal with what's otherwise a really widespread fear of abandonment. And the final point comes back to the point I made earlier on equity. We really ought to be informed by a robust notion of social justice, which means that we need the fair distribution of beds, home care resources, and so forth, but also a thoughtful examination of what's going on in terms of impoverished people, people who don't speak English, and so forth, and how can we put better resources in place. So the bottom line for this is that proceeding with care means also examining our social and healthcare resources in general, so that people have a better chance to flourish as much as possible wherever they're at on their living or dying journey. This sounds perhaps a bit like utopia, and we don't have to get it perfectly, but we need to move there more and more progressively. And so that is where our work really ought to head toward. And I do want to say that in this talk, if in 2002, any of you have been in a class with me, you've heard me rant about the abandonment of the Romanow Report. If we had followed the Romanow Report, I'm here to shake my fist at governments for just mothballing the Romanow Report in 2002 as soon as the federal government changed. That report would have done a huge amount. It wasn't perfect, but it would have done a huge amount to have moved us toward a much more socially just system, because Romanow was looking not just at healthcare delivery, but also things like better support for rural healthcare, better support for Aboriginal peoples, dealing with the crazy pharmaceutical costs, and so forth. There was a lot of wisdom in that report, which in 2002 was remarkably widely accepted by all the professions, which is in itself unique, and also was consistent with some values analysis across Canada that had happened at the same time. So these are not impossibilities. It takes political will and political change that our professional associations are in a place to be able to move forward on as well. But before I go into specifics on policy action, which is where I'm going to go next, I do want to put out a big warning here in terms of ethical reflections. And that is, this slide is, the values reflected in this slide will be blown right out of the water if coercion enters into this. So statements such as that physicians or healthcare providers or agencies cannot refuse to participate in physician-assisted death are dangerous. That's a non-technical word of putting it. But if we start to force providers or, for example, Catholic health agencies to participate in the active hastening of death, and there is a moral difference in all kinds of theology and ethics work, and we force them to do it or threaten their funding, which is something that came up on the news not long ago, then we have created, instead of this positive package of ethical benefits, we have created a climate of fear. And that is about the worst way to move forward with any initiative like this. So I really want to underscore that we have to absolutely make sure that there is room for conscientious objection on the part of individuals as well as healthcare agencies, and we have good protocols for that. We've been dealing with that in terms of the option of abortion, for example, for a while, but there's been rhetoric coming around that individuals can't refuse and or agencies can't refuse. Now, this is not ensconced yet, but it is incredibly important. And here I'm informed by a wonderful colleague who's Dr. Nuala Kenny, who is one of Canada's foremost leaders in healthcare ethics work. She wrote the report on Canadian values before the Romanow Report came out. She is an amazing scholar. She's retired from as a professor of philosophy at Dalhousie. She's a physician, a pediatrician, a Catholic nun, and a fireball, and one of my favorite people on the planet. I've had a chance to do some ethics and policy work with her, and she is deeply concerned about the conscientious objection latitude within some of the initiatives that are moving forward. So we have a chance to make a difference as individuals, as nurses, as citizens, and also within our nursing associations and nursing bodies to make sure that these kinds of concerns get talked about. And so what I'm going to do is move on to some policy action points, but again, I think it would be nice to maybe pause now for question or comments, and we'll give the people online a chance to type anything they want to ask or comment on, and as I said, feel free to disagree, but just any points from the audience you'd like to raise at this stage, and again, I'll repeat them. Are you okay with the pace and the speed and all the rest right now? But great, thanks. It's way easier than being on the radio. Thank you. So Wendy.
So, Paddy, this is really fascinating, but you kind of jumped over proportionate intervention.
Yes, yeah.
So could you say a little bit about that?
Yes, sorry. I did jump over proportionate intervention. So thank you for that, and it was one that I added purposefully. That one of the things that we've tended to do in acute care is we've said, well, this intervention like a ventilator is just too much because it's a ventilator, or this inotropic drug that's going to keep blood pressure up is just too much because it's an inotrope. Or we've said in palliative care, well, going for surgery if you're in palliative care is inappropriate because this is palliative care. The focus is on the intervention, not the intervention in context. And some of the better writing, thanks for catching my skip in my excitement, Wendy, of missing that one because it's an important point, is we ought to be analyzing, is the intervention proportionate in this context? So, for example, sometimes a trial period of ventilation or inotropes can be entirely appropriate. It is a matter of staying and following through the journey. This is a process of good ethical decision making. And certainly our palliative care colleagues now tell us that sometimes, for example, surgery to relieve a bowel obstruction can be proportionate on a dying journey. And also there's now work in palliative care on palliative sedation where people may be put into an actual coma because their symptoms are so difficult to manage. So instead of focusing, is this intervention too big or small by itself, we always ought to ask in relation to what's going on for that individual, is it proportionate? Did that help? Thanks. Yeah, thanks you for catching that. I would have kicked myself if I'd gone home and looked at this and realized I missed saying more about that. Any other comments or questions in the room? Online? Nope, we're good.
Hi. No, it's Andrea Burrows.
Oh, Andrea, welcome.
Thank you. I'm from Royal Inland Hospital. I'm the staff development educator, and I want to thank you so much for talking about the climate of fear and how important that is. I just did an in-charge workshop, and one of the staff there were just very passionate in vocalizing how important it is that they feel comfortable that when they're faced with an order that says increase dilaudid without, and it's not a PRN order, that they also have the confidence and the comfort to be able to question that order and also provide their assessments, and so perhaps making a different conclusion to something like that is, I think, very important. So I just want to say thank you for that. Is just so important in this.
Well, thank you. And I think the point too with, I'm not a palliative care expert, but my understanding with the dilaudid, for example, or if it's for palliative sedation, is morally and legally the intent is not to kill the person, although that may happen. It's a secondary effect that they may die from the palliative sedation. But if the intent is focused on matching, as you know, the medication with the level of suffering and pain, often, as we know, it doesn't necessarily depress respiration and so forth. But but it may have as an outcome a secondary effect of hastening death, which is different than the physician-assisted death, where there's a very conscious, purposeful sedation before the paralytic muscle agent. But regardless, I think the point you've raised is, if somebody's feeling uncomfortable about why are we doing this, and is this actually hastening death, are we sneaking the Dilaudid up in a way to try to have somebody die more quickly without the discussion, or even with the discussion, people have to feel safe to have this conversation. We do know from research on moral distress that it lasts for decades, that there's a combination of moral residue. Work by Lynn Musto and others indicate that it may well be linked to, and we don't have all the empirical or theoretical work, but may be linked to things such as critical incident stress and so forth, compassion fatigue, that we are affected as providers, that our well-being should never trump the well-being of others, but certainly we have to be able to take care of ourselves and have our own conscience guided by the principles that we believe from our code of ethics, as well as our own individual faiths, to be respected. And we know that healthcare flourishes when that happens. So thank you for the Dilaudid example. Did that answer your question?
No, that was excellent.
Thank you.
Thank you.
Any other comments? That was a good one. Thank you. So let's go on to what indeed will we do about this. So what I've done so far, just to recap then, is to point briefly to some empirical reflections about the kind of challenges we have in our healthcare system, well documented by lots of research that run right through the gamut, all the way from high acuity critical care, acute care, into community care, long-term care, and so forth. And we know that there are inequities in resources in all of those fields. There's also, of course, a lot of strength and a lot of improvement, but we have a long way to go. And so when we look at those systems of care, and we have the individual who is on a serious life-limiting illness trajectory or chronic illness trajectory, we need to be able to understand how we can address those resources in an equitable manner to help support them, whether that's toward physician-assisted death request or toward a palliative care end. That it's not so much which direction they choose, but there have to be solid and viable and robust options for them to choose from. And in our current system, there is a significant danger that those people who are most marginalized are going to have the fewest good, if you will, good options. So in terms of policy action, what I want to do is summarize some points about where we ought to, how we ought to look at policy. Because in order to move beyond repeated problems at the individual level, we need to look at the larger system level and say, how can we as nurses, our colleagues in other professions, our colleagues in palliative care have a huge amount to offer here, so do our colleagues in acute care and all other areas. And this is something that the Joint Center for Bioethics is arguing for, is we really need to come together to work this out. And again, why statements by the Canadian Nursing Association, the Association of Registered Nurses of BC, and so forth become really important. Nobody can do this by themselves. I believe, and this is a point that didn't come from the Joint Center, and I'll point out when some of what I've got comes from the Joint Center, but we do know that if we truly embrace the notion of primary health care, we're already dealing with a lot of the challenges that I've pointed to. And this is a CNA initiative as well, that primary health care, and remember, the terminology is a little crazy here. All of you know this, but and I'd like to kick whoever helped have this happen. But there's a big difference between primary care and primary health care, which probably most of you know. Primary care is usually used to mean point of contact. Who do you first go to and get treated by? Primary health care is a philosophy and a management system and much more complex. And the two get mixed up all the time. So be careful about the terminology. Primary health care, which by the way right now this year is one of CNA's major initiatives, are guided by principles of accessibility. So that would mean, for example, if we had robust accessibility, we would have, for example, much better access to resources such as interdisciplinary clinics, which have been proven to do a really good job for fields like chronic illness, available in urban as well as rural communities, for instance. Public participation means that we have a healthcare system where we have the public listened to in terms of what ought to be offered and what their concerns are, and in helping to shape what's needed within different communities. Health promotion means that even if we think of somebody on a dying trajectory, there's still health promotion within that in terms of their own mental health, their grief, and certainly for the family. And I do want to point out as an example, there's not a reference in the list on this. If you're interested, I have one through the work with technology evaluation in the elderly, which Jennifer and I are part of, now called Canadian Frailty Network. There's been some research by some of the researchers in that group showing that if an end-of-life experience goes badly for the family, often in terms of over-treatment, the post-traumatic stress for the family is significant and has huge health impacts later as well. That's relatively new data, but it's morally significant as well. That health promotion ought to run through everything that we do. And indeed, I'm stretching primary health care, but I would argue that we really need a health promotion lens for healthcare providers also. That it's not that our well-being trumps that of who we are serving, but if we don't pay attention to our need to be listened to our need to be able to have our concerns heard, for example, a safe place to talk about the dilaudid in the previous example, we know that that problems with moral distress, stress, illness, and so forth, and attrition are significant challenges. By the way, that's especially for our new graduates. They're a particularly vulnerable group. And I would never argue, again, I've said it repeatedly, but it doesn't have to be an either or. It is a both and. Our well-being and the well-being of the patients and the families and the communities that we're serving. So health promotion means health promotion within illness and disease, as well as health promotion in its more usual sense of well baby clinics and so forth. Appropriate technology means then, goes back to that proportionality principle that Wendy mentioned, is that we use technology wisely, and there can certainly be times when a high-tech intervention can be entirely appropriate if it is planned and evaluated on the basis of facts, values, a careful history, and if there's an ongoing reevaluation. What tends to happen with technology is it's getting better, but there's been a widespread fear, for example, if you initiate a tube feed or a ventilator, you can't stop, which is absolutely incorrect, both legally and morally, but there tends to be a fear of trying some appropriate technological interventions because of the fear that we can't back off. But that is not true. If we reevaluate and get different facts and consults, we can certainly use that technology appropriately and then use the evaluation of it to figure out what's proportionate for the individual. It's also the case that we need intersectoral cooperation. And certainly, this is where the relationship between, for example, social services, financial services, and healthcare are incredibly important, given how much financial stability affects the resources for health. And so pharmaceutical costs are a huge example of that there are people who will ask to stay in hospital longer because as soon as they walk out the door, they don't have the money to pay for their pharmaceutical resources. So that is not just a healthcare problem, that is a social problem. And a robust system of primary health care, and we have elements of it happening, will certainly help us move forward. And I believe that if we truly had equitable and effective palliative primary health care across the board, the request for physician-assisted death and the need to provide that would be quite small in number and very specific in scope for some very particular, for example, some of the neurological and other disorders where there really is, even with the best that palliative care and other has to offer, there is not necessarily a good ending where physician-assisted death can be helpful. But what we don't want is it to be a fill-in for the fact that somebody's lonely, afraid, has no support at home, and feels they're being a burden to their family. Because some of the data from the States and other places shows that kind of influence can creep in. And we certainly do not want it creeping into non-voluntary, and going back to that coercion. And again, going back to looking at the reports that are out from the JCB and other places, there's been concern, and this came up in 1994 when there was a Senate Committee on Euthanasia and Assisted Suicide that they called it then assisted suicide and said it could not go forward. But the Senate committee then pointed out that there was non-voluntary starting in places like the Netherlands or Belgium even then, and that remains a concern. So we really ought to be asking careful questions about how do we have an equitable healthcare system based on the principles of primary health care so people don't feel abandoned and see that as a last resort or have others decide for them. I've pointed out repeatedly that we need to integrate a palliative approach to care, and more specialized palliative services is needed. And that means that palliative care, and Dr. Kelly Stajahar from UVic has written about this beautifully and is leading a team called iPanel. There's some references to her work within the bibliography, is that we ought not to see like you're palliative care or you're not as a binary. We ought to say instead, we start palliative care as soon as somebody has some kind of a chronic or life-limiting illness, and that the principles of a palliative approach in terms of pain and symptom management, grief support, support for the family, and so on ought to start right away. We ought not to wait till somebody's right at the edge of death to provide palliative care. And so that palliative approach is thought of, there's a new paper by the CNA out on this that references this as well. The palliative approach, if you think of palliative care as a triangle with the wide base is a palliative approach that ought to be accessible just about everywhere. The tip is the very small percent of people who need the really extensive palliative interventions, for example, in a palliative care unit. But palliative care, a palliative approach to care ought to be available throughout. So somebody who is diagnosed with a chronic illness, such as, going to Jennifer Gibson's example, congestive heart failure, ought to have the chance to start those conversations early with they and their families. Not saying, oh, there's an X mortality rate, what do you want to do about it? It needs to be done carefully, but talking about this can be a difficult journey for people. Let's talk about what that's going to be like and start initiating that palliative approach early, and then know when they need the more specialized palliative services. Certainly, and as I pointed out, it means attending to the social determinants of health, to anticipate potential harms using the precautionary principle. So that means, for example, if we know that non-voluntary is happening in other places, we better start asking who's going to be most vulnerable to non-voluntary euthanasia, people who don't have family support, people with mental health concerns. We ought to really be very, very careful about anticipating potential harms. And the other point is, and this links to our philosophy of science, if you will, that I think we can be really proud of at the School of Nursing, and this is where our research teams are so important, is we really need robust mixed methodological studies to look at evidence in planning and evaluating physician-assisted death. So if we start down this road, we better plan it based on evidence and not just a few randomized control trials, but a robust notion of evidence that looks at people's experience and so forth, and there's good work out there, but also look at how we can evaluate physician-assisted death, which, as you'll see, is a major point in the Joint Center for Bioethics component as well. So we're naive if we think people won't feel pressed into doing this, if they're lonely, alone, and impoverished. And again, the data, there's a lot of fighting about the data about how much this happens in other places that are doing it, but there's been enough indication over the years that it is a significant concern. And so we do need to take our best use of robust evidence to this. The next, the final slide before I mention resources and we go to any closing comments is, we're only going to get this right if we don't fight with each other and we collaborate across within the disciplines and all the specialties. And so that means our ethics colleagues, our social science colleagues, our physician colleagues, our palliative care colleagues, our acute care colleagues. We need places to come together on this. And I hope that the Canadian Nursing Association and other groups will continue to foster this. Certainly the Joint Center for Bioethics is. And we need to involve government in this. By the way, our current provincial government is starting up a group of those of us who do work in ethics to start working with some of the insights from the Joint Centre and other places to have more conversations, and that this will be part of our recommendation. One of the things that the Joint Centre says that I really like in this is, instead of fighting, this person has a right to die and you have an obligation to make that available, instead of getting into an individualistic rights-based arguments, we ought to look at how can we have overlapping consensus. So let's look for the complexity. And yes, we agree that this level of suffering is not tolerable. What are the options we can come at it with? And yes, one of those options might be physician-assisted death. But to turn it into a right trumping another right is not a good way to go. Do you follow what I mean on this? Really important, because there's a legalistic heritage to this, and legalistic heritage means rights versus rights. So we need a broader dialogue than that. And certainly we need reflection and feedback at all levels. And we have a particular requirement to pay attention to those who are most marginalized, as I said before, and also something that Dr. Joan Anderson, my mentor and a mentor for many of us in the school, has pointed out on the basis of her research, is understand that vulnerability can be situated as well. So she has a classic case she's written about where an elderly man and his wife were dealing with a serious illness. They were extremely well off. They lived in West Vancouver. They had family support, and they were totally overwhelmed, as many of us would be. So while we absolutely have an obligation to pay attention to those where the social determinants of health are a problem, it's also the case that anybody can be vulnerable based on context. So we also don't want to overlook how situated vulnerability can have an effect. So the final slide before the reference, it is really a reference, is that tells you about what the Joint Center for Bioethics is up to. And again, this is quite recent, within the last year. Literally, they started last April. They've been doing a great deal in terms of looking at modeling policy, educational materials, resources for patients' families, and ethical guidance on how do we decide about competence and so forth. And then there's a long list of other references for you. So I think we're probably at about a couple of minutes toward closing before the next. I haven't seen anybody outside the door yet, but we do have a class coming in. So I can pause now for more questions or comments. So let's go online first, see if anybody wants to say anything, and feel free to challenge anything I've said as well. Nothing online yet. How about in the room, or any comments or anything you'd like to say? Yeah, Wendy, thanks.
I'm a little anxious about this comment, but one of my graduate students that was in my office having a conversation with me was talking about infants against at home that have been born prematurely on ventilators that are actually arresting on their ventilators at home.
Right.
And this whole framework is all about competent adults.
Right. Right.
About life trajectory and grievous suffering.
Right.
And I just wondered where you saw children in this whole mix.
Yeah, so that's a good question, and I'll paraphrase it for the, so if I paraphrase it wrong, let me know. But Wendy's raising a question that she's worried about, that I fully agree, that what about, that we're talking about competent adults, but what about, for instance, infants living at home on a ventilator who are arresting constantly, children of other ages, what does it mean to think about what physician-assisted death might mean for them? And I think what the Joint Center has recommended is that they haven't used the phrase proceed with care, I've tacked that on, but everything that I've read and understand is that it may become appropriate for that kind of context, but we have to be so careful to start getting it right when we've got explicit consent. That's one of the reasons that mental health also was taken off the list for the current legislation, as I understand. And the challenges with mental health are, it's part of the disease process potentially as well. How do we sort that out? So there are absolutely very thorny questions. This is only a beginning point. What we do know is if we go too fast and overrun evidence consensus, we have a chance of getting things catastrophically wrong. And in that case, catastrophically wrong for people who can't speak. On the other hand, if we get it right, we have a chance to relieve suffering in a way that could have meaning for families and others. And none of this precludes appropriate treatment withdrawal as well, because we always have treatment withdrawal at our disposal. So the removal of a ventilator, the initiation of palliative care, for instance, ought to be a valid option that's considered by all. And we too often don't have those withdrawal of treatment conversations, which are absolutely proportionate in terms of both ethics and the law if we do them and set up that conversation early. So there's a comment on the phone, and then I start to see people out there. So we'll move.
So the online question is, what are your thoughts on tabling the legislation now and having to open it up in the future to accommodate the specialty groups? Advanced directives, emancipated minors, and mental health?
So the question is, what are my thoughts about having the limited group now, but having to open up the legislation later for emancipated minors, people with mental health problems, and so forth? I'm not a legal expert, so my quick answer is going to be I don't know, which is not what you're supposed to say as an academic. But I think that we're going to have to, it goes back to the groups getting together and asking these questions together, that we really need to bring in experts who know about, for example, Wendy's issue of what's it like for families and infants dying at home. People who work with people who are emancipated minors, so people like Elizabeth and others who have tons of research and expert background, people who work with people with mental health challenges. We're going to have to bring those groups together to have different kinds of conversations than we have if we're going to get it right. The dangers are very real, and I personally find some of the data a bit alarming out of what's happening in Europe, potentially about non-voluntary, that ethicists often get criticized for warning about a slippery slope. That is, if we start here, we'll slide down. There's a lot of debunking these days of slippery slope. This is potentially a very difficult and dangerous slippery slope. Jennifer, you wanted to say something, and then I think we'll head out. Thanks.
I just wanted to comment on the way this law produced itself in Canada, which is, it's not that a bunch of people sat around and said, you know, we should really think about increasing the options for people at end of life. The way it happened was there was
Yes.
a human rights challenge
Yes.
that went to the Supreme Court. And so particularly in end-of-life issues in Canada, the law seems to be made on the backs of the people who are suffering.
Yes. Yeah.
And this is an unfortunate way that legal challenges come. So rather than having a legislative approach where we proactively look at an issue, we wait for a case to go through, you know, every level of court, and that means that an individual patient and their family suffers through the experience of changing the law in this country. And so the answer to your question is, what is going to happen is that there will be a court challenge from an emancipated minor. There will be a court challenge from someone who has a disabled family member. That's how the laws can be made, unless we do things differently in this country. But so far, this is unfortunately how the law changes.
I'll work on a paraphrase for that for our group. Jennifer, that was incredibly eloquent, and I hope you're writing that. Jennifer's made an excellent point about one of the challenges with this legislation. It's been based not out of a group of legislators getting together, say, let's resurrect Romanow and all the really good thinking of all the stuff that I've just talked about, and be creative, constructive, bring diverse communities together. Instead, it's been launched on the basis of a human rights course challenge with one individual who is suffering, whose suffering is used to launch this. And that sets us up for a bit of a rights versus rights kind of approach. And certainly it means that it is much harder to have the kind of constructive dialogue that we need to have happen. And your worry is, and I think it's a valid one, is the widening of the scope will be other challenges from emancipated minors and so forth. And I believe that the most important thing we can do is be incredibly proactive within our professions and say, look, this has come up out of a court case, but let's get it right. Let's have the robust conversation. And that's why I love what the Joint Center said about we need overlapping consensus, not rights-based discussion, not rights-based, they didn't call it fighting, but that's basically what happens when you get rights against rights. It's a fight. So I think that there is a much better way to proceed. We do have the evidence, the expertise. You've been an amazing group, including those of you online. I know I've totally crowded the people outside. And I just want to say that it's a wonderful opportunity to be part of this. I'm happy to get input, critiques, anything like this. It's still thinking that all of us are doing, and including myself. Thank you so much for the opportunity.